Imagine this. You wake up on a Tuesday morning. The sun is coming through the window. You make your coffee. You feel fine. Actually, more than fine. You feel good. You're 74 years old and life, honestly, isn't bad. You're sleeping. You're moving around. You're enjoying your grandkids, your garden, maybe your fishing trips. Nobody is worried about you. You are not worried about you. And then your doctor's office calls. Just a routine checkup, they say. Nothing serious. We just want to run a few standard tests. It's what we do at your age. So you go. 6 weeks later, you are sitting in a surgeon's office. Not because you felt sick. Not because anything hurt. Not because something was wrong. You are sitting in a surgeon's office because a test, a routine test that was supposed to protect you, found something. And that something triggered a chain reaction inside the medical system. A chain reaction that your body, at 74, was simply not built to survive without consequences. And the life you were quietly, peacefully living, it looks completely different now. Here is the part that should make your blood run cold. This is not rare. This happens every single day, in hospitals and clinics across this country, to people exactly like you. People who walked in healthy and walked out into a nightmare that started with 2 words. Just routine. For the next 20 minutes, I'm going to tell you something that most doctors will never say to your face in a 15-minute appointment. I'm going to show you 5 common, widely accepted, completely standard medical tests that, after the age of 70, carry risks that nobody is properly explaining to you. I'm going to show you the data. The real data. Not the pamphlet your clinic hands you in the waiting room. The actual research, the actual outcomes, the actual stories of real patients whose lives were permanently changed by tests they were told were just to be safe. And at the end, I'm going to hand you 5 questions, 5 specific questions, that will completely transform the dynamic the next time you sit down with your doctor. Stay with me through all 5, because number 3 is the one that stops people cold when they first hear it. And number 5 is the one that almost no one is talking about, until it's too late. Let's begin. Before we get into the 5 tests, I need to give you one idea. One lens. Because without it, everything I'm about to tell you will sound alarming without being useful. I call it the longevity lens. When you are 50 years old, screening medicine is brilliant. You catch a problem early, you treat it, and you potentially buy yourself 30 more years of healthy, active life. The math is clean. The investment makes complete sense. But here is what changes after 70. 3 things, specifically. The first thing that changes, many conditions that get detected by routine screening in older adults will never actually harm you. They grow slowly. They produce no symptoms. In many cases, you will simply outlive them. The problem is that modern medicine does not have a leave it alone and monitor button that is easy to press. It has a treatment button. And once a finding appears on a report, that button gets pushed, almost automatically. The second thing that changes, your body's tolerance for medical intervention is fundamentally different at 75 than it was at 55. The surgery that a younger person recovers from in 2 weeks can mean 3 months of complications, loss of independence, or something far worse in a 78-year-old. Age changes the equation in ways that medicine does not always stop to account for. The third thing that changes, and this is the most dangerous thing I'll say today, is something called the cascade effect. One test finds a small abnormality. That small abnormality triggers a follow-up scan. The scan recommends a biopsy. The biopsy leads to a procedure. The procedure causes a complication. And suddenly, a person who walked into a clinic feeling completely healthy is now navigating a medical emergency, one that started with a test they didn't even need. That is the longevity lens. Keep it in your mind as we go through each one. Let me tell you about a woman I'll call Dorothy. Dorothy was 77 years old. Retired schoolteacher. Sharp, warm, completely independent. She had 2 colonoscopies in her 50s and 60s, both completely clean. No polyps, no family history, no symptoms of any kind. But when she got a new primary care doctor, he looked at her chart and said she was due for another one. Dorothy had concerns. She'd read a little. She wasn't sure she needed it, but she didn't want to seem difficult. She didn't want to be that patient. So she agreed. The preparation for a colonoscopy, the liquid you have to drink the night before to completely clear your bowels, hit her kidneys hard. By the next morning, she was confused. She was dizzy. She could barely stand up. Her daughter rushed her to the emergency room before she ever made it to the procedure itself. She was severely dehydrated. Her electrolytes were so dangerously low that her heart was at risk of going into crisis. Dorothy spent 4 days in the hospital. She never had the colonoscopy. And here is the devastating irony: she never needed it in the first place. The United States Preventive Services Task Force, the gold standard body that establishes screening guidelines in this country, officially recommends against routine colonoscopy screening for average-risk adults over the age of 75. The evidence is unambiguous on this. After 75, if you have no symptoms, no family history, and clean previous results, the risks begin to outweigh the potential benefit. And those risks are real and they are serious. A bowel perforation, a literal tear in your colon, occurs in approximately 1 out of every 500 colonoscopies. In a younger adult, that is a manageable surgical complication. In a 77-year-old, it can mean emergency surgery, a colostomy bag, months of hospitalization, and a recovery that fundamentally and permanently alters your quality of life. Meanwhile, the colon cancers most likely to be discovered in asymptomatic older adults tend to grow so slowly that, in many cases, they would never cause any problem during that person's remaining lifetime. What to do instead? Ask your doctor about a non-invasive stool-based test. Options like the Cologuard test or an annual FIT test can detect genuine warning signs without any of the procedural risks. And if you do have symptoms, blood in your stool, unexplained changes in bowel habits, that changes the equation entirely. See your doctor immediately. But a routine scope just because you hit a certain age, after 75, that deserves a much harder conversation. That is the longevity lens. Keep it in your mind as we go through each one. I need to be very precise here, because this is a topic that deserves real nuance. I am not telling you to avoid cancer screening. Cancer screening has saved millions of lives. It may have already saved yours. What I'm telling you is this: after the age of 75, aggressive screening for cancer in average risk, asymptomatic individuals has a serious and well-documented problem called overdiagnosis. And overdiagnosis leads directly to overtreatment. And overtreatment, in older adults, causes genuine, measurable harm. Here is what overdiagnosis means in plain language. Imaging technology today is extraordinarily sensitive. It can detect cancers that are, biologically speaking, barely active. Tiny, slow-growing tumors that, if left completely alone, would never spread, never produce a single symptom, and never shorten your life by a single day. You would die with them quietly, not from them. But the moment a radiologist writes the word malignancy on a report, the entire clinical machine turns on. Biopsies, specialist referrals, treatment discussions, all of it moves forward, regardless of whether that particular cancer, in that particular person, at that particular age, actually poses any real threat. Consider a man I'll call Richard, 79 years old, retired mechanic, still sharp, still independent, still fishing on weekends. A routine PSA test came back slightly elevated. A biopsy confirmed a low-grade, slow-moving prostate cancer. His urologist recommended radiation therapy. Richard trusted the recommendation. He had no reason not to. He went through the full course of treatment. Within a year, he was dealing with chronic fatigue, persistent urinary problems, and a quality of life that had dropped dramatically from where it was the morning he walked in for that routine blood test. Stories like his are documented extensively across the medical literature. Men and women who, looking back, wish someone had told them clearly, "Your cancer is the kind that a person your age would almost certainly have lived alongside peacefully, not died from." If that conversation had happened, everything might have been different. Major studies published in leading medical journals found that a significant portion of cancers detected through routine mammography screening in women over 70 were clinically insignificant, meaning that treatment provided no survival benefit whatsoever, only side effects. What to do instead? Have a direct, honest conversation with your doctor about your specific situation. If you have a family history, genetic risk markers, or symptoms of any kind, then screening is absolutely appropriate. But if you are average risk with no symptoms, ask this question directly. If we find something, what are the realistic treatment options at my age, and what would you actually recommend we do? That single question often changes the entire conversation. This one surprises people, because it sounds so responsible, so logical. Your doctor looks at you and says, "You're 72. Let's just make sure your heart is holding up okay." You get on a treadmill, or they give you a medication that temporarily stresses your cardiovascular system, and they monitor your response. It sounds like basic, sensible care. Here is the problem. Cardiac stress tests in people who have no symptoms produce false positive results at rates that can reach 40% or higher in certain age groups. That means nearly half the time, the test flags something alarming, when your heart is actually functioning perfectly fine. But medicine cannot just shrug at an abnormal result and move on. That false alarm immediately launches the next phase, a cardiac catheterization, which means threading a thin tube through your blood vessels, through your wrist or groin, directly into your heart, to get a closer look. It is not a minor procedure. The risks include bleeding, vessel damage, dangerous heart rhythm changes, and in rare cases, the procedure can actually trigger the very heart attack or stroke you were trying to prevent. And here is where it becomes genuinely counterintuitive. If that catheterization finds a partial blockage, which is extremely common in adults over 70, many of whom have absolutely no symptoms, you may end up being recommended for a cardiac stent. Multiple major clinical trials, including a landmark study called the ischemia trial, found that placing stents in patients with stable coronary artery disease did not reduce heart attacks and did not extend life compared to medication management and lifestyle changes alone. Read that again carefully. The stent did not outperform the alternative, but it carried its own real procedural risk, and then a lifetime of blood-thinning medications with their own complications. So the journey looks like this. You felt perfectly fine, you had a routine stress test, the test triggered a false alarm, the alarm led to a catheterization, the catheterization led to a stent, the stent led to blood thinners and ongoing monitoring, and at the end of all of that, you are statistically no better off than someone who simply managed their risk factors with medication and a 30-minute daily walk. What to do instead? If you have no chest pain, no unexplained shortness of breath, no dizziness during physical activity, then routine stress testing is looking for problems in a population where problems are common but intervention does not reliably help. Ask your doctor about optimizing your actual risk factors: blood pressure, blood sugar, cholesterol, sleep, and physical activity. That is where the genuine lasting gains are. This one makes people uncomfortable, because the fear behind it is completely legitimate. Osteoporosis is real. Falls in older adults are devastating. Hip fractures are genuinely life-altering. So let me be very careful here. I am not questioning whether bone loss happens with age. It does. I am questioning a specific and very common pipeline, the one where a DEXA bone density scan leads automatically and almost reflexively to long-term medication without an honest conversation about what that medication actually involves. Here is what often goes unmentioned in that conversation. Long-term use of the most commonly prescribed bone medication, a class called bisphosphonates, drugs like alendronate, has been associated with a rare but serious condition called atypical femoral fracture. These are spontaneous stress fractures in the thigh bone, the very bone the medication was supposed to protect. These fractures can be severe and require significant surgery. These medications are also linked to a condition called osteonecrosis of the jaw, deterioration of the jawbone that is extremely painful and very difficult to treat. Now here is the thing that the research is very clear about. The single most effective intervention for preventing fractures in older adults, more effective than any medication, is not a pill. It is fall prevention. Balance training, specifically, reduces fall risk dramatically. Studies on Tai Chi practice alone show a fall risk reduction of close to 50%. Removing tripping hazards from the home. Installing grab bars in the bathroom and shower. Reviewing medications that cause dizziness as a side effect. Getting vision checked regularly. Ensuring adequate protein and vitamin D in the diet. These interventions, taken together, reduce fracture risk more meaningfully than medication, with zero side effects. There are absolutely patients who need bone medication, people who have already experienced fracture, people with very low scores on the bone density scale, people with specific identified risk factors. For those individuals, medication is the right conversation. But a routine scan leading to automatic long-term medication for an active 74-year-old who has never broken a bone, has no significant risk factors, and is otherwise in good health, that is a conversation, not a foregone conclusion. What to ask your doctor? Before we discuss medication, can we do a full review of my specific fall risk factor? And what does the actual data show about fracture risk reduction from this medication compared to a structured fall prevention and balance training program? This is the one almost nobody is talking about. And based on what the research consistently shows, it may be the quietest and most consequential item on this entire list. A carotid artery ultrasound examines the large blood vessels on each side of your neck that carry blood to your brain. The concept behind screening for it sounds completely logical. If we find a significant blockage, we can remove it surgically and lower your stroke risk. Makes sense, right? The reality is far more complicated, and for people who have no symptoms at all, it is far more dangerous than it sounds. Here is the critical fact. the surgical procedure used to treat a carotid blockage, a surgery called a carotid endarterectomy, carries a 2 to 3% risk of causing a stroke during or immediately after the procedure itself. In older adults with other health conditions, that risk is even higher. The United States Preventive Services Task Force explicitly and specifically recommends against routine carotid artery screening in adults who have no symptoms, no mini-strokes, no episodes of vision loss, no neurological warning signs of any kind. Their analysis found that in asymptomatic people, the risk of harm from surgical intervention outweighs the benefit of finding and treating the blockage. Here is why. Many people over 70 have some degree of narrowing in their carotid arteries. That narrowing, in most cases, has been there for years. It is stable. It is silent. It is not causing any problems whatsoever. When you screen for it routinely, you find it. And when you find it, a well-meaning surgeon recommends fixing it. But the surgery to address a blockage that was never causing symptoms can, and sometimes does, dislodge a small piece of plaque that then travels directly to the brain. The medical literature on this is not ambiguous. There are documented cases of people walking into a routine ultrasound appointment and leaving on a completely different life trajectory, not because of the blockage that was discovered, but because of the intervention that followed. What to do instead? If you have no symptoms of stroke or TIA, no sudden vision changes, no facial drooping, no arm weakness, no sudden severe headache, no episodes of confusion, then routine carotid screening is generally not recommended by the major medical bodies. The far better investment of your energy and attention is in controlling the actual modifiable stroke risk factors: high blood pressure, which is the single largest stroke driver, blood sugar, smoking cessation if relevant, management of atrial fibrillation, and staying physically active. If you do experience any neurological symptoms, even brief ones that resolved quickly and seem to pass, get evaluated immediately. That changes everything. But in the absence of symptoms, the evidence does not support routine screening. I promised you something practical. Here it is. Every single time your doctor recommends a screening test, especially if you are over 70 and currently feeling well, I want you to have these 5 questions ready. Write them down. Put them in your phone. Bring them to every appointment. Question 1. What is the false positive rate of this test in people my age? This tells you how likely the test is to generate an unnecessary alarm and set off a chain of follow-up procedures, even when nothing is actually wrong with you. Question 2. If this test finds something, what are the realistic treatment options for someone my age and in my current state of health? This forces the conversation away from just the finding and toward actual real-world outcomes. Question 3. What is the procedural risk of any treatment we would likely pursue? This is the question most people never think to ask. Every procedure carries risk. You deserve to know what that risk is before you are in the middle of it. Question 4. What happens if we choose to monitor this instead of treating it immediately? For many conditions discovered in older adults, watchful waiting with careful monitoring is not just acceptable, it is often the superior choice. You have the right to know that option exists. Question 5. What is the most effective non-invasive intervention for this condition? Because as we have seen today with bone health, heart health, and stroke prevention, lifestyle adjustments and appropriate medication frequently outperform procedural intervention with dramatically less risk. Any good physician will welcome these questions. They will respect you more for asking them. And if a doctor dismisses these questions, makes you feel difficult, or makes you feel like you are being unreasonable for wanting to understand your own care, that is important information. That is information about whether that particular doctor is the right fit for you. I want to leave you with one thought. There is a profound difference between medicine that finds things and medicine that helps you live well. After 70, the purpose of your health care should not be to generate finding. It should be to protect and extend your quality of life, your independence, your energy, your ability to do the things that actually matter to you. The very best physicians understand something that the medical system does not always reward or encourage, that recommending watchful waiting sometimes takes more wisdom than ordering another test. That doing less, in the right circumstances, is not laziness. It is courage. You have the right to know what a test is looking for. You have the right to know what happens if something is found. You have the right to ask whether a finding would actually be treated, and whether that treatment would genuinely, meaningfully improve your life. Medicine has given us extraordinary tools, but tools are only beneficial when they are used in the right context, at the right time, for the right person. You are that person, and you deserve healthcare that is built around your goals, your values, and your body, not around a checklist. Take these questions to your next appointment. Ask them out loud. You may be surprised at what changes in that room when you do. Take care of yourselves. I'll see you in the next one.